I previously rated Lemtrada as the second most effective disease-modifying therapy in multiple sclerosis based on its potential to induce long-term remission without further treatments, but it does come with significant risks, including infections and secondary autoimmune diseases. Today, let's take a deep dive into how it works, the results of clinical trials, and the potential side effects along with safety monitoring, and I have some timestamps if you want to skip ahead and references below. Let's have some fun. Full disclosure, I was a blinded EDSS rater in one of the clinical trials for Lemtrada several years ago, but I was not compensated for this, and I have no financial conflict of interest. I would strongly suggest you talk to your own provider because Lemtrada is no joke, but if you have some general questions, I'd be happy to answer in the comments below. By the way, my name is Beaber, and I make videos about multiple sclerosis every Wednesday, so please subscribe and ring the bell for notifications, and if you enjoy the video, please click like. Alemtuzumab was originally developed to treat chronic lymphocytic leukemia, a cancer of the white blood cells, under the trade name Campath. However, it turns out that inflammation in multiple sclerosis is largely driven by the adaptive immune system, specifically the B and T lymphocytes. And so this drug was repurposed under the trade name Lemtrada to treat multiple sclerosis. Lemtrada itself is a monoclonal antibody depicted here, which targets CD52, a cell surface protein in B and T lymphocytes. It binds this surface protein and causes the cells to lyse or break apart. Now, it specifically targets adult mature lymphocytes, and so the bone marrow later regenerates these lymphocytes. Of course, you need an immune system, but the cells come back with different immunological properties, which is why long-term remission is possible in some cases. And here you can see the CD4 positive T cells being depleted to almost 100% shortly after treatment with Lemtrada, and they slowly come back after about a year, and then the second course of Lemtrada causes them to go down again. And here you can see the B lymphocytes, the antibody-producing cells, again going down after treatment with Lemtrada, and they come back a little bit more quickly, actually rising above baseline levels by 6 months. Now, it turns out B cells come back a little bit more quickly than T cells, and that may have something to do with one of the side effects of Lemtrada, which is developing secondary autoimmune diseases we'll talk about later. It turns out that when B cells come back in the absence of regulatory T cells, so the immune system sort of regulates itself, this can lead to secondary autoimmune diseases, and people have talked about various strategies to prevent this, such as giving other immunosuppressant drugs, but really there's no standard way to prevent this complication. Now, in terms of the logistics of the treatment, typically you want to complete any needed vaccinations at least 6 weeks prior to starting Lemtrada because its effects on the immune system can reduce the effectiveness of vaccinations. So the flu vaccine, the pneumonia vaccine, the varicella or shingles vaccine, if indicated, should be given beforehand. Now, the treatment itself is given through the IV, usually in an infusion center, and the dose is 12 milligrams per day, daily for 5 consecutive days for the first course. Then you do no treatments for 1 year, and a second course of 3 treatments given daily for 3 days is given 1 year later. Now, after that, there's a potential for long-term remission, so you don't necessarily need any future treatment for the rest of your life unless there's evidence of return of disease activity. For instance, if you have a multiple sclerosis relapse or if you have new lesions on MRI scans, and usually doctors will only recommend further courses if you have at least 2 new lesions on MRI scans. So with 1 new lesion, they may sort of let it ride and see if there's continued disease activity. Now, each infusion takes about 4 hours, and there is a very high rate of infusion reactions. So typically the drug is given with steroids, specifically 1,000 milligrams of methylprednisolone or solumedrol for the first 3 days of each treatment course. So if it's a 5-day course, you would get steroids for the first 3 days, and some providers recommend other drugs such as Benadryl, Tylenol, or famotidine. Also, there's a high rate of herpes viral infections with Lemtrada, And so antiviral preventative medication is given usually for 2 months or until the CD4 positive T cell count rises above 200 per microliter, whichever occurs later. And this is to prevent things like cold sore outbreaks, genital herpes, or disseminated shingles, which can occur with Lemtrada. Now, the half-life of the drug Lemtrada itself is only 2 weeks, and very low levels of the drug are present after 1 month, but the effects of the drug on the immune system are very prolonged or even indefinite because the immune system comes back differently. Now, in terms of susceptibility to infections, the nadir or lowest point of the B and T cells is about 1 month, so that's when people are kind of most susceptible to infections, and the B cells recover at about 6 months, but the T cells recover much more slowly. Next, we'll take a look at the results of some of the clinical trials. So here we're looking at CARE-MS2, which is a randomized trial of Lemtrada versus Rebif. Rebif is a high-dose, high-frequency beta interferon considered to be a lower efficacy disease-modifying therapy for multiple sclerosis. Because Lemtrada does have some significant side effects, they thought it wasn't good enough to beat placebo. They really wanted to show that Lemtrada was better than other disease-modifying therapies. And here we're looking at relapse-free survival, the percentage of people who did not have a relapse during the 24-month or 2-year study. And you can see it starts at 100%, and then people start having relapses, and the lines start going down. But many more people had relapses taking Rebif than taking Lemtrada. And there's a little bit of a therapeutic lag. So during the first 3 months, Lemtrada wasn't definitively better, which is typical of these studies. But by the end of the study, 47% fewer people taking Lemtrada had relapses compared to those taking Rebif. Next, we'll look at sustained disability progression. So here we're looking at EDSS, or Expanded Disability Status Scale, and I have a separate video on that if you want to take a look. And so they measured the disability in people with MS and saw if they worsened over time. And if someone had a brief fluctuation in disability, they didn't consider it to be too significant. But if someone had worsened and then 6 months later was reevaluated and still had increased disability, they considered that to be sustained disability progression. And so this is 6-month sustained disability progression. And you can see the red line in which is Rebif. Many more people taking Rebif had sustained disability progression compared to those taking Lemtrada. In fact, those taking Lemtrada had 42% less sustained disability progression. The MRI outcomes were also favorable for Lemtrada. Far fewer had new active or gadolinium-enhancing lesions in blue compared to Rebif in red, and you can see what gadolinium-enhancing lesions look like to the right. And this was also true for new T2 or enlarging T2 lesions. There were fewer with Lemtrada compared to Rebif. But how effective is Lemtrada in the long term, even after the drug is stopped? Do people really achieve long-term remission? Well, this is data from the TOPAZ study, the 8-year extension study of the original CARE-MS 1 and 2 randomized study, and the data look very favorable. Here we're looking at the number of courses of Lemtrada that people received, and by the way, this study had very good follow-up, about 74% followed up for the full 8 years, and very few people changed to different disease-modifying therapies, less than 5%. And you can see that the majority of people had exactly 2 courses, 53%, so they did not require any additional courses of Lemtrada, but some people did. So 27% of people had 1 additional course for a total of 3 courses. 13% of people had 2 additional courses, or exactly 4 courses total, and a small number of people needed 5 or more courses. And the data in terms of prevention of relapses looked better and better even after the drug was stopped. And so here we're looking at the ARR, or annualized relapse rate, which is the number of relapses on average per person per year. So let's take a look at year 2, which is after the second course of Lemtrada, and you can see the annualized relapse rate was 0.1. In other words, 1 relapses every 10 years on average, or 1 relapse in a year in 10 patients. So out of 10 people, only 1 has a relapse over the course of the year. And this is very good compared to the baseline relapse rate of this patient population, because they had relatively active disease prior to entering the study, but it gets even better. In year 3, 0.06, in year 4 and 5, 0.05, 1 relapse every 20 years. In year 6, 0.02, one relapse per 50 years. This is excellent. The data in terms of disability also look great as more people improve than worsen. So here we're looking at confirmed disability worsening on top compared to confirmed disability improvement on the bottom. And so this is 6-month confirmed disability worsening. And you can see it starts off at 100%, and this is the percentage of people who are free of worsening. And in year 1 and 2, it's 94 and 91%. But by year 8, 22% of people did worsen at some point, but 78% of people were free of confirmed disability worsening. But what about confirmed disability improvement? 21% improved in the first year and 31% in the second year, but by year 8, more than half of people, 53% improved. So more people improved than worsened. And if you look at overall average disability, this is EDSS. So the average disability was an EDSS of 2.3 at the start of the study, which is relatively low disability. And people tended to get a little bit better and then remain stable over the 8 years. And even after 8 years, people were on average better than they were 8 years ago, which is very impressive. Now, of course, there's a lot of individual variation, and some people who did poorly may have not followed up. There could be a little bit of follow-up retention bias in the study. The MRI data is also pretty good even 8 years later. So this is the percentage of people who are free of new or active lesions on the MRI. Now, year 1 wasn't so great. 68% of people were free of new or active lesions. And again, there may be some therapeutic lag where the drug isn't very effective for the first 3 months. But by year 2 and 3, it was in the 80s in terms of the percentage of people who were free of new or active new T2 lesions. And by the end of the study, it was in the 70s, still relatively good, and still the drug is effective even years after the last treatment. And it was also effective at preventing brain atrophy. So multiple sclerosis is a disease that's associated with accelerated loss of brain volume. Now, everyone is losing brain tissue even with normal aging. A typical person, even without MS, loses about 0.2% of their brain volume per year, but in multiple sclerosis that can be accelerated. But in people taking Lemtrada in the blue line, they had less brain atrophy compared to people taking interferon, and people have done longer-term studies and shown that brain atrophy reduces to the level consistent with normal controls without multiple sclerosis even several years later. But this comes at a cost, as Lemtrada can cause significant side effects. For instance, it can cause infusion reactions, it can weaken the immune system and cause infections. As the B cells come back without T cell regulation, it can cause secondary autoimmune diseases, and it's associated with rare cases of cancer, in particular thyroid cancer, melanoma, and cancers of the immune cells themselves. So thyroid cancer occurred in 3 out of 919 people, or 0.3%, and melanoma also occurred in approximately 0.3% of people taking this medication. Now, the most common side effect is really infusion reactions, which occur really in close to 100% of people, and it can cause rash, fever, and hives, though rarely more serious infusion reactions can occur, such as angioedema, such as swelling of the tongue and lips and mouth, or anaphylaxis, a systemic immune reaction, and even heart attacks can occur with infusion reactions, although that's very rare and much more common when Alemtuzumab is used to treat leukemia or lymphoma. But serious reactions do occur in about 3% of people, and about 0.6% of people needed some kind of antidote for their infusion reactions, such as epinephrine or atropine. So this is an example of hives which can occur with the infusion. Now, of course, the immune system is temporarily weakened, especially early after the treatment, and herpes viral infections can occur in about 16% of people, usually cold sores or genital herpes or shingles, also known as zoster. Human papillomavirus, the cause of cervical cancer, or cervical dysplasia can occur, which is why it's important to follow with a gynecologist if you have a cervix. Tuberculosis can occur with this medication, and fungal infections such as athlete's foot or vaginal yeast infections, but sometimes serious, rare, opportunistic infections can occur such as listeria, disseminated shingles, CMV, pneumocystis jirovecii pneumonia, nocardia, and several other rare infections. And this is an example of shingles, a painful rash. Secondary autoimmune diseases can also occur. Now, luckily, most of these autoimmune disorders, occurring in about 34% of people taking Lemtrada, are thyroid disorders, which are relatively mild and usually easy to treat. So this can cause Graves' disease or hyperactivity of the thyroid, or Hashimoto's thyroiditis, which is a reduced activity of the thyroid, sometimes causing permanent thyroid damage and requiring another medication to replace thyroid hormones such as Synthroid for the rest of your life. But rarely more serious autoimmune diseases can occur, such as immune thrombocytopenia, an autoimmune attack of the platelets leading to bleeding problems occurring in 2% of people, or inflammation of the kidneys, antiglomerular basement membrane disease occurring in 0.3%, or lysis or breakdown of the red blood cells, hemolytic anemia, occurring in 0.2%, or acquired autoimmune hemophilia A causing bleeding, or other autoimmune diseases such as rheumatoid arthritis, type 1 diabetes, vitiligo, or another autoimmune disease such as acute inflammatory demyelinating polyneuropathy known as Guillain-Barré syndrome, or CIDP. These diseases are rare and usually treatable. This is an example of bleeding under the skin, petechiae, caused by immune thrombocytopenia and bleeding in the mouth. And this is a kidney biopsy in antiglomerular basement membrane disease. There's some other side effects as well, such as cholecystitis or inflammation of the gallbladder. This usually occurs due to a stone that blocks the common bile duct, but in people taking Lemtrada, you can get acalculous, in other words, without a gallstone cholecystitis, often requiring antibiotics and surgery. This occurs in about 0.2% of people, and about 1 in 200 or 0.5% of people can have pneumonitis or inflammation of the lungs. And because of these potential side effects, special screening tests are recommended prior to starting Lemtrada, and then after receiving the treatment, special monitoring tests are done. For instance, you should have certain blood tests such as thyroid stimulating hormone to make sure you don't have existing thyroid disease, and a complete blood count to look at your red blood cells and platelet levels. If you have a cervix, you need a Pap smear to look for cervical dysplasia, and a skin exam to make sure you don't have skin cancer that you didn't know about it. Women should be counseled not to become pregnant before or slightly after receiving Lemtrada, and it may be a good idea to check for varicella antibodies because of the risk of shingles, and if you don't have a history of varicella vaccination, you could consider getting the Shingrix vaccine. You also need to be screened for tuberculosis with gamma interferon or the skin TB test, and you also need to be screened for hepatitis B, C, and HIV prior to treatment, all of which are considered to be contraindications to this drug. And even after completing Lemtrada, you need to be monitored for at least 48 months or 4 years to make sure there are no secondary effects. For instance, you need monthly blood tests with a complete blood count, again to look at the platelets and the red blood cells and to make sure your immune system is coming back after treatment. The kidneys need to be evaluated by a urinalysis and the creatinine test, and yearly skin exams to look for skin cancer, and thyroid stimulating hormone every 3 months. The risk of thyroid disease peaks at about 3 years but can sometimes occur several years later. I'll add a few special considerations for pregnancy and breastfeeding. Now, Lemtrada is not studied in pregnancy and is generally not recommended. In animal studies, such as in mice, it doesn't seem to cause birth defects, but may be associated with an increased rate of spontaneous abortions or miscarriages. It's actually recommended not to conceive for at least 4 months after receiving Lemtrada, just because having a weakened immune system while you're pregnant can be dangerous, particularly with respects to certain types of opportunistic infections, such as listeria, which can be very harmful to the fetus. Also, the risk of thyroid disorders does pose a problem. For instance, if the mother has Graves' disease, there's a risk to the infant of getting what's known as neonatal Graves' disease. Now, it doesn't mean you can never become pregnant. It's just that you have to be monitored for these disorders and appropriately treated. It's not recommended in breastfeeding either because Lemtrada is detectable in the milk of lactating mice, and it can actually lower the lymphocytes of the offspring who consume the milk. In male mice, there's some evidence that Lemtrada may contribute to abnormal sperm morphology and reduce sperm count, but interestingly, in animal studies, there was no reduction in fertility. So I hope the video was useful to you, and if you have any further questions, please post in the comments below and take a look at my resources. And if you've actually taken Lemtrada for MS, I'd be interested to know your experiences. Please share in the comments below and let me know if you have any suggestions for future videos.